everyone. It's right at 12 Central, so we'll go ahead and get started. My name is Larissa DeLuna, and I'd like to welcome you to the American Heart Association Stroke Webinar Series. These educational webinars are being brought to you by the Southwest Affiliate Stroke Committee. All webinars will be held the last Wednesday of each month from 12 to 1 Central Time. For a full list of upcoming webinars, visit heart.org/SWA Quality. Before we get started, we'd like to go over a few housekeeping items. To avoid background noise, all lines have been placed on mute. For questions, you can unmute your line by pressing *6 or type a question in the Q&A section of WebEx. Although this is not an accredited CE/CME event, attendees will receive a certificate of participation as proof of attendance. All slides, handouts, participation certificates, and bios for today's speaker will be sent to attendees within 2 weeks of today's call. Please also visit heart.org/SWA Quality for a recording of today's webinar. Today's webinar is focused on innovations in post-stroke rehabilitation. Today's presentation will be given by a panel from Houston Methodist Hospital's Rehabilitation Services. I'm going to turn it over to Kathy Currier-Buckingham to get us started.
Hello, everyone. We're so glad that you're joining us today and have a passion, as we do, for rehabilitation. We're going to talk, we have some objectives for today. I think the news that we're giving you is not necessarily going to be earth-shaking, all of it, but we hope that it will guide and reinforce and then show you some new resources along the way. But to reinforce signs and symptoms appropriate for therapy and especially some outcome measures that might be predictive. Because we wanted to talk about all of the predominant disciplines in therapy, I have a panel of speakers. Cara Lally is a PT, board-certified neuroclinical specialist, and Nicole Slater is also a PT, board-certified in neurology, physical therapy. Carolyn Martinez is a speech-language pathologist with extensive experience in stroke rehabilitation, and Judy Scarbeck is an OT with a master's in rehabilitation science, and she also has an extensive experience with persons with strokes. So these are the objectives. We're going to loosely look at hospital therapy considerations, PT, OT, and speech, what happens when they're in the hospital, some considerations, and then look at what happens in post-acute care, which would be, we're particularly focusing on rehabilitation unit, but DME and treatment interventions would also apply to outpatient and SNF. Okay, someone go move the screen. Point it, move it. Okay, we already, why don't you go ahead and start talking and then we'll go on. We're having difficulty moving the slide on the fear. So, here we go. Somehow we got to slide 15.
Would you like me to bring it up on my screen?
Yes,
yes
please.
Okay, 1 second.
So I stop sharing. I'm so sorry for the... Can you bring it? You got it, Larissa?
Yes, I'm trying to bring it up on my end.
Do you want to go ahead and start talking, Cara?
Okay, I am Cara Lally. I'm a physical therapist here in, work primarily in the acute care setting here at Houston Methodist. So I was going to go over a few things to start with related to physical therapy side of things. Perfect. And then the next slide is where I will start there. So as part of a comprehensive stroke center, so that our care is standardized upon admission, all of these patients, this is the therapy side of things that automatically get entered as part of the stroke order set. So consult the PT, OT, as well as speech, and that includes the dysphagia and dysarthria screen. Okay, next slide. Okay, so our department a couple years ago collaborated with our primary stroke neurologist to set a department protocol after the patients who have had a TPA administration. So the neurologists really felt strongly about the current research that is out there to actually have us start our evaluations within after 12 hours from TPA administration. We still do consider the patient a high fall risk if they are within their 24-hour from TPA admin. So at that time, if they still fall within that 12 to 24-hour range, we will complete our evaluation, but then return them to bed just because of the risk of hemorrhage with a fall risk. So that's something that we worked very closely with our neurologists for standardization of care across our department. Next slide. So the StrokEDGE recommendations, I don't know how many of you are familiar, the Academy of Neurological Physical Therapy, which is a division under the APTA, came out with this update, which was published last year in 2018. So it's the second follow-up, and what they do is they go through all the current literature and research, and based on the setting, provide the most highly recommended measures based in the acute care. So this is kind of a reference point. I would recommend you all using that if you are trying to set a protocol yourself. We use this in large part to create a guideline and decision tree made for our post-stroke patients at HMH, which I'll go over here briefly in a second. This helped us to provide the best practice based on current evidence. So you can see the highly recommended items, including the Orpington, the postural assessment for stroke patients, and then the stroke rehab assessment of movement are all highly recommended, as well as some other core measures. Next slide, please. So this is the decision tree that we have implemented here within our department at Houston Methodist. And I won't go into it. You can kind of read for yourself there how we go in to decide and really incorporate some sort of outcome measure for each of our stroke patients. And that's something that we have required in our department and did extensive training with our stroke therapists in order to standardize our care so that all of our team members have an understanding of where the patient is functionally. Also, this is helpful because if another therapist follows after the evaluation, or the patient goes on to inpatient rehab or other settings in outpatient, these can be repeated there so they can kind of see their progress along the way, all the way from a high level to a low level. The one I am going to focus on here briefly is the Orpington Prognostic Scale. You can remember that that was on the highly recommended measures from the StrokEDGE 2, and it's something that has more recently come to light for us. And so if we go on to the next slide, it's a highly predictive, valid tool, and it's a little more uncommon, but we have been using it pretty extensively here in our setting. It's very good to help with a predictive tool for discharge disposition, which is something that we start from the get-go from our evaluations. We're always planning for discharge. So we use this. It can go from a high-level patient all the way down to a low-level patient, and you can see in the research it's correlated highly to the NIH stroke scale in the acute phase, and it's actually a little more effective in predicting their functional status later on. Next slide, please. So I wanted to briefly kind of give you some visual of what is included on the Orpington Prognostic Scale. So this slide, as well as the next slide, it encompasses everything that's included. So there's 5 total sections: the motor deficit in the arm, proprioception, balance. There's a cognition mental test score. And if we go on to the next slide, you'll see the rest of it, the strength of the lower extremity, as well as it goes into the specific cognition questions. Next slide, please. So those are you can see the mental test score based on Hodgkinson's. We have modified a couple of those to be more relevant to the current population. Instead of years of First World War, we have now changed that, and we use the year of the Twin Tower collapse, and then instead of name of monarch, the name of the president. So next slide, we'll look at the scoring. So, and I apologize, there's 5 sections. I had put 4 sections originally. The motor deficit in the arm, as well as the motor deficit in the affected limb, and this is the affected side. the proprioception, the balance, the cognition. So your total score, you always add the 1.6 plus each of those sections. And it's really nice the deficits get categorized, and based on that, it can help us influence our discharge disposition recommendations. So under that mild deficit, these patients are likely very low affected and can discharge home. In the moderate, we're looking at a rehab versus a SNF, and then that's where our other factors from our evaluation come into play at determining between the two. And then a severe or major deficit, these patients are likely dependent and may require some institutionalization. So as soon as we evaluate, I kind of alluded to this before, but targeting appropriate discharge recs, working closely with our case managers, this screen and test has been very helpful in us determining that. Next slide, please. The last thing I wanted to touch on briefly is our frequency here in the acute care side after a stroke. So the AVERTS trial is one of the most frequently referenced studies in current research. It stands for a very early rehab trial after stroke. So if you just, and there are 3 phases of it, if you just looked at the bottom line conclusion, in reading that, you would think, oh, increased frequency, increased mobility is not good for these patients. However, this study actually looked at a high amount of dosage, so high that it was 2 times a day, 6 days a week, and whatever way possible, they got these patients out of bed and upright, whether it was using lifts, slings, whatnot. And that high frequency is often not feasible here in the acute care setting. The other thing that is important to consider is that they actually started this within 24 hours of the stroke symptoms instead of 24 hours of the order placed, which here in Comprehensive Stroke Center for Standardization of Care, we see these patients within 24 hours of our order placed. Often the patient isn't even to the hospital and order placed within 24 hours of their stroke onset. So those are considerations, to consider when you're looking at the AVERTS trial conclusion. Bottom conclusion, shorter, more frequent mobilization is associated with a more favorable outcome, which is great because here in the acute care setting, that's more in line with what we're able to provide. Next slide, please. So here at Houston Methodist, I wanted to go over some considerations for how frequently we see these patients for physical therapy as well as occupational therapy. So some considerations, and you can bring into play in your own setting: prior level of function, the acuteness of the stroke, their medical stability, and then their activity tolerance and their level of function at time of evaluation. So PT is generally between 3 to 6 times a week in our hospital, and you can kind of see there for reference where we would go for maybe a lower level patient, or on the opposite spectrum, a higher level patient who can mobilize with the nursing staff as well. 4 times a week, they have a fair tolerance, they have a moderate prognosis. 5 times a week, they have a good prognosis, unable to safely mobilize. And then those 6 times a week are those that it would be a detriment to them if they miss more than 1 day of therapy. Our OT frequency is a little bit lower just because of staffing and what we're able to provide. So generally, the stroke setting is between 2 and 4 times a week. So those 2 times a week, low level, decreased activity tolerance. 3 times a week, working on seated level ADLs, and 4 times a week, they have a good prognosis for recovery. And I know Judy, who will be speaking here shortly, can kind of go into that a little bit more in depth. Next slide is just the references that I kind of used throughout this portion.
We'll take questions at the end, but we'll move on to the occupational therapy information. Judy Scarbeck.
Thank you. My name is Judy Scarbeck. I'm a senior occupational therapist currently working in acute care on the stroke unit. If you can go on to the next slide. Next slide.
I hit it. Is it not showing on your end yet?
No.
No. Oh, there we go.
Okay.
So I threw this slide in just to give everyone an opportunity to see from a nursing standpoint how it sets the stage for us within the therapy realm. These are outcome measures that we use here at Houston Methodist as a standard of care within the ICU as well within the stroke unit. And it's good for the therapist to be familiar with these. We do get training in these at all association levels, national training, et cetera, just so you're familiar with what potentially these stroke patients are going through at the ICU level as well from a nursing standpoint. Next, go ahead to the next slide. So within our outcome measures, this is our best practice that we're using here at Houston Methodist. We decided on this a year or so ago within our current literature that's being practiced within the OT world. And so we looked at using the Postural Assessment Scale for Stroke, also known as the PASS, the Barthel Index for ADL, as well as CATS for ADL. And we look at using the MOCA for a simple assessment in regard to cognition. And we're also using the Geriatric Depression Scale to be able to assess these folks. Again, a nice standard of practice that's being used here at Houston Methodist. Next slide. I wanted to give you guys a little idea of how the PASS works. It helps us from an occupational therapy standpoint, again, for our standard of care here, because the PASS is looking at the patient in a lying position, a sitting position, or also standing. And these are all things that we look at from an occupational therapy standpoint in order for the patient to be able to practice and participate in self-care. And so this is very much an emphasis in acute care. We look at positioning to be able to do our self-care activities. So it's also a very good area that we like to be able to assess. It also had wonderful reliability and validity, and it gave us wonderful positions to be able to look at for the patient. The nice thing is it kind of, some of the research is giving us indication of what's a safe score for an older adult as well as what is a good indicator for their safe walking. I also attached the link there that you're able to go into and take a look at the whole scale itself. You can also find the scale on the StrokEDGE website as well. On to the next slide. Other items that we look at in regard to outcome measures for our standard of care, we use the Mini-Mental, the AMPAC, FIM because it helps us prepare for our patients from acute care, moving them over to the next level of care of rehab. We also use the functional reach. We look at modified Ashworth scale so we can look at their tone. We also use the 9-hole peg test to look at coordination. We also do a patient health questionnaire, which is another level of depression scale. Trail making to look at other and detailed cognition as well as draw a clock. We also do a visual screen, and this helps us prepare for any person who may have neglect or body awareness issues, as well as just overall interpretation of their environment. In the ICU setting, we are using the JFK CRS as well, and that helps us with being able to get a functional ability of that patient at the ICU level. We are using these and seeing these within our literature from an occupational therapist standpoint. On to the next slide. Since we concentrate on positioning and self-care in acute care here at Houston Methodist for our standard of care, I wanted to be able to show you some of the modalities that we're using. And we use kinesio taping that you see on the left, as well as McConnell taping that you see on the right. And again, these are very important for us in preparation for the patient to be able to perform their mobility as well as to be able to perform their self-care skills. So we're very much addressing the positioning and the upper extremity while they're here in acute care as well as self-care. And the next slide. Other areas, you'll see general splinting as generalized, standardized practice across the continuum within all acute cares. We use a splinting, the resting hand splint. This is just one example of one of the resting hand splints. We're also using them in collaboration using the edema gloves for edema management for the stroke upper extremity as well. Again, a standard of practice across most inpatient acute cares. Next slide. Other items that we look at for potential the modalities that we might use include the slings any sort of sling that may be helping to position the patient again. Looking at current research is using a lot within functional E-stim. Kind of went away a little bit, but now it's back in practice again. FES attended to help with some facilitation and being able to, again, position the patient and prepare them for self-care. In this slide, you see a POSI splint device to help with some elbow extension, as well as a finger spreader splint to help with edema control and positioning of the upper extremity. Next slide. We talked about positioning, but we also begin self-care, getting the patient out of bed and getting them prepared into a chair position to work on some vision, cognition, in relation to self-care and ADL. Also, we begin at this level in advancing the patient to start doing some home program and patient direct teaching as well. So we really engage the patient in body awareness activities through self-care. Next slide. In addition to doing the self-care, we also work on our general modality that you'll see. It's a standard of practice again, and we get the patient actively working and being able to do their self-range of motion, active range of motion, as well as facilitation, fine motor skills, sensory training. Big emphasis on family training and safety so that we can, when the patient has their own time, we give them some homework to be able to emphasize that movement. That movement is good for them in regard to stroke recovery. We emphasize with them in regard to safety throughout, as well as beginning to continue on with patient-family training, which is utmost importance there. And next slide. Attached with that is some references. These are very current materials in regard to references for the occupational therapist working in acute care.
Thank you. Next we have Kristen Lloyd helped with this presentation, but Carolyn Martinez, speech-language pathologist, will do the presentation today.
Okay, and I think that was supposed to also include, I'm Carolyn, that was include dysphagia as well as communication and cognition in the stroke population. So, okay, moving on to the next slide. So dysphagia is a common morbidity in this population. We know we can't always rely on a lesion site to predict the presence of dysphagia. In our literature, there's a wide incidence of dysphagia occurring from 25 to 81%. It's been found that on a modified barium swallow study, up to 40% of patients may demonstrate some aspiration, and of that 40%, maybe even 40 to 70% of it is silent aspiration, which is not eliciting any overt symptoms. So this is an area that definitely needs to be looked at, as it can lead to pulmonary complications, malnutrition, dehydration, so important to look at. So next slide. Typical dysphagia features, we all kind of think about coughing with swallowing or a wet voice while eating, poor management of their secretions, pocketing, food spilling out of one side or the other, or holding of the food. However, another two pivotal features also include dependence for feeding and a dependence for oral care. Those proved to be very high indicators for pneumonia on a pivotal study done by Susan Langmore. And of course, our stroke population individuals, these folks fall into that category. Next slide. So the dysphagia screen is performed usually by a nurse here. All of our patients are receiving this screen, whether it's done in the ED, the ICU, or the floor. Some of these patients are placed on diets prior to being seen by the speech pathology group. However, our group is still evaluating these patients, at least with a clinical bedside swallowing evaluation. So next slide. Okay, so this is just a list of some various dysphagia screens that have been normed on this stroke population. Most all of them include some general assessment of level of alertness, looking at oral motor integrity or weakness, and obviously administering some various forms or various volumes of thin liquids. If you go to the next slide, we use here at Methodist, so we had a speech pathologist involved in the selection of the dysphagia screen here. So we use the Barnes-Jewish Hospital Stroke Dysphagia Screen. This screen, per the literature, shows a sensitivity to showing the presence of dysphagia at 94% and the sensitivity to aspiration at 95%. Next slide. What we do, our general battery here for assessing our patients, again, every patient is at least seen for a clinical bedside swallowing evaluation. That is looking to see if we need to move on to an instrumental examination, so modified barium swallow or a fiber optic endoscopic evaluation of swallowing, otherwise known as FEES. So those two exams, the instrumental modified and FEES, modified barium swallow and FEES exams, will analyze the swallow physiology. That's where we can implement maneuvers, strategies, diet modifications, and those are the only two that will identify the presence of silent aspiration. Next slide. Wanted to include just a couple dysphagia resources. Of course, ASHA has some, National Foundation of Swallowing Disorders, and there is specific to stroke there. The next slide. So one thing I did want to bring up is our group, the speech pathologists, have collaborated with dietitians, food scientists, another group, many other professionals working on this initiative called the International Dysphagia Diet Initiative. The purpose of this group was working on a way to standardize a way of naming and describing texture modifications and thickened liquids, meaning that a nectar-thick liquid is the same viscosity at one hospital to the next hospital. There can be some changes, or a mechanical chopped is the same diet texture from one hospital to the next. So this group sought out to find a common language among all these professionals. So this is a contrast to what traditionally is being used right now. What they're trying to get away from is a national dysphagia diet. I hear from our dietary group that we're going to be working with them to change this in 2020, so that's exciting for us here. All right, next slide. So wanted to bring up the involvement of language and cognitive impairments after stroke. It can be found up to 72% of these patients may have some form of a cognitive impairment, presence of dysarthria, aphasia that might affect their communication. Next slide. Excuse me. Wanted to, I know Judy touched on a couple of these cognitive screeners that can be used by the nursing staff, residents, physicians. We may use one of these during our clinical bedside swallowing evaluation, just to assess if we need to look at this individual further, teasing through communication, cognitive impairments that might be even subtle. So next slide also has a couple more. So the mini-cog, the 4AT, if you move to the next slide, the MOCA, and the mini-mental. So common cognitive screeners. Next slide. So the speech pathology group here, we use a variety of standardized aphasia batteries, cognitive assessments. I didn't list them out. It's probably specific site, what you have in your arsenal, or what you prefer also as a speech pathologist. So some of these patients receive maybe a more standardized battery, maybe in the post-acute setting. In the acute care, we have a kind of a non-standardized tool that we look at, again, for modalities of language, some cognition, safety, awareness, insight, problem solving. So again, if the speech pathology group should be consulted if there's a presence of aphasia, dysarthria, even voice concerns after a stroke, or if an individual may need to utilize some sort of a augmented or alternative communication device, a speech-generating device. we help our patients acquire and learn how to use those devices. Again, a couple more resources, ASHA, I guess I really liked ASHA on this talk, and the Cognitive Communication Checklist resource. So the next slide, I think, is just my references. There we go. Thank you.
Okay, next presenter is Nicole Slater with the help of Kayla Butler. Nicole works currently in our inpatient rehabilitation hospital, but has extensive experience with persons that are out of the acute care setting.
Hi, y'all. I'm a senior PT in the inpatient rehab. I'm going to start with, next slide, please, low extremity positioning and support. We follow through with a continuum of care from acute care, and hopefully we are the last stop in-house before home and outpatient. In rehab, patients receive 900 minutes over 7 days of PT, OT, and speech combined. That works out to about 3 hours a day over 5 days per week, and I'll talk a little bit more about that later. So back to the lower extremity positioning and support. The nursing administration in bed, the PRAFOs are basically a positioning device that can help keep the patient's leg in neutral, so it helps with dorsiflexion and decreases excessive rotation with a kickstand, and then also floats their heels, so it decreases the risk of pressure injuries on their heels. If those are not available or if the patient can't handle it, you can always use pillows and wedges to accommodate that as well. And then we help with the nurses with that. And then from a therapy standpoint, when we're treating the patient, we can work on standing and ambulation, some of the taping that Judy had talked about earlier. If you don't have the resources to get something like an off-the-shelf custom AFO, the ankle-foot orthotic, then we can use an ACE-strap or TheraBand to kind of mimic that as well. When we do need to get an AFO, we'll consult a prosthetic and orthotic specialist so that they can help us determine the most appropriate one for a patient. Next slide, please. The electric stimulation that we use in our clinic is on the left-hand side there, the Bioness L300 Go and an FES bike called the RT300. Electric stimulation has shown to result in significant improvement in functional status, shown to reduce spasticity, increase muscle mass, reduce edema, and can result in improved motor learning. The L300 Go is basically a device that can be hooked up to your dorsiflexors, and we can use it during gait training as well as functional transfer training. And then if they need a thigh component, there's a thigh component that can stimulate the quads and the hamstrings, and you can use them independently of each other. The RT300 bike, we can stimulate the hemi side, the upper extremity, and then the non-involved side will still push along, and then the same thing goes for the lower extremity. We cannot do upper and lower at the same time, but we can incorporate the trunk with upper and lower. Next slide, please. When a patient cannot ambulate, when they're not a primary ambulator, we'll order them a custom manual or power chair. That has to be done with a ATP, which is an assistive technology professional, and a PT or an OT. We will order them a ultra lightweight manual wheelchair, especially for our stroke patients because they need to propel with one side of their body, so it's going to be more of a hemi height that a regular wheelchair cannot accommodate. And key language for us is that patient is not a safe functional ambulator, or I should say ambulator, not ambulatory, which basically means that they're non-ambulatory in the wheelchair world. The keywords for physicians is on the right side there, the ICD-10 codes. The paraparesis, hemiparesis, quad, and polyneuropathy, really more hemi, para, and quad is crucial for the ultra-lightweight wheelchairs and for the power chairs. If a patient cannot propel a chair, we will use power mobility. there's a tilt and recline function so that they can pressure relief if they become really orthostatic when they're in like a regular chair, and that's on the right side over there. And then we have a wheelchair clinic with our PM&R docs that the patients can follow up in, and then the ATP is there as well to do any modifications that need to happen with a chair. Next slide, please. We have an exoskeleton and upper extremity robotics here. I am not very well versed on the upper extremity robotics. I can maybe defer to one of the OT here if needed. And the exoskeleton that we use it for postural alignment, for pre-gait, gait retraining, all that stuff over there. And we have found that it improves the efficiency with gait. Something that we found in our clinic as well is that we get in really good steps with this, and we see clearance of the hemi limb almost immediately after some of our patients do it just once. And it has all the advantages of a standing program as well, and it's a fully weight-bearing device too, which is kind of nice. Next slide, please. This is the Academy of Neurological Physical Therapy, the one that Carl referred to as well, but this is more specific to inpatient rehab unit. And I'll let you guys read that. I don't need to read through that. Next slide, please. Caregiver training. This is like one of my favorite parts of inpatient rehab because we get to teach the family how to help the patient, whether it be in the room, when they're in-house, or when they go home. We teach them in movement using neuroplasticity, forced use it or lose it, and a lot of the family members do follow through with it, and it provides training to ensure safety when assisting with a patient. I want to minimize the surprises for the patient and the family upon discharge, so we go over transfers in and out of cars, whether it's a sedan or an SUV. If we need to do it in the patient's actual vehicle, we'll arrange it with the family, and then with basic transfers in and out of the bed and locomotion if it's appropriate. The offloading tips and for pressure relief, it's the positioning that I talked about on the first slide. And if they need pictures of the patients, we can take pictures with the family members' phones so they have it for everyone to be able to reference. Next slide, please. The frequency and dosing is what I was talking about a little earlier. It's hard sometimes to get the 900 minutes per week, so the way that we do is we try to overschedule our patients by scheduling 3.5 hours, 6 days a week. We strongly recommend that the patients still get out of bed on that 7th day. It's not necessarily a day of rest in bed, but we just can't schedule 7 days a week. The carryovers, nursing and family, they also help because we're not here 24/7, and if the family's here, then they can help, and all of our nurses are trained to assist with transfers. We meet weekly for team conferences, and that's every discipline that's on the patient's team. And then we have dry erase boards in every patient room to show the staff how we help transfer the patients so that we keep it continuous across all disciplines. Lastly, next slide, please. We are CARF accredited. It's a stroke specialty program. CARF is a gold standard for showing the specialization in comprehensive rehabilitation of patients and their family, as well as a transition to home. And that is it from rehab.
Last slide, please. Next slide. Larissa, can you move the slide?
Which one were you needing?
51. Do you have it?
51 is references.
Yes, we have references. And coming soon, back one slide, The future for rehabilitation in general will include virtual reality. We actually have an opportunity in our piloting some goggles, virtual reality for pain relief on our rehab unit with certain patients who have pain, which may include stroke. Some telehealth is involved and becoming used, as many of you know, in like heart failure and some other areas. But we're thinking in the rehab realm of how do we communicate to make sure our families post-discharge or in the outpatient setting that we can check in with them and refresh exercises. Upper extremity robotics, we alluded to, they're getting more sophisticated and more portable, more like the lower extremity exoskeleton. So we're looking at the future there, and as you look at buying equipment, these are things that, again, I think across what you're hearing is that the more practice of functional movement during recovery is beneficial to our patients regardless of what setting they're in. So these are just ways to do that. At this point in time, we'll open to questions. And Larissa, if you would move to the next slide. I can serve my email if you have a question that you can't stay on the line for or want to email something, reference material, or just send us a question. You'll see my email. I'll point it to the right speaker in-house. So we open the floor to questions. Larissa, will you moderate those?
Definitely. So we don't have any questions in the Q&A section of WebEx, but if anyone would like to use that, feel free to type your questions in there. Also, if anyone would like to come off *6 to unmute your line to ask a question. And as people are doing that, I'll just give a reminder that we'll be sending slides, the recording, and a copy of all of our speakers' bios to everyone within 2 weeks. And your certificate of participation will also be in that email. So be on the lookout for that. I don't see any questions coming in. Would anyone like to *6 and ask any questions? And *6 to come off mute. There's nothing in the Q&A section.
Well, we're available through email for questions. We appreciate it, and we'd love to hear what your centers are doing. So if you've got some different information, certainly there are different ways to do stroke rehab, but we were very pleased and honored to be able to share what we're doing with you today. Thank you.
And we're so appreciative of your team giving their time to get the presentation ready and to present for us today. Thank you so much. I don't see any questions coming in, so we'll go ahead and give everyone a few minutes back. But thank you so much for your participation.
Thank you all.
Thank you.
Thank you.